Thank you, Liz. We'll be recording only the speakers section of today's webinar. And then once we move to the open question section where we'll hear from the audience and have some more collaborative conversations, we'll be turning the recording off. And that's not to limit the opportunities for those people listening to the recordings, but to create that sense that we're all in this moment here in time, and to, I guess, enhance people's sense of safety and collaboration in those conversations. So it's 3 minutes past 12. I'm here in Sydney. So welcome everyone to the very first Manna Institute webinar series. My name is Associate Professor Sarah Wayland. I'm also going to turn on the captions for anybody that might need those, if anyone has any hearing issues, and they're available if people need to use them. So I just wanted to start by sharing an acknowledgement of country. And this is a beautiful acknowledgement that has been written specifically for Manna Institute in collaboration with our Aboriginal and Torres Strait Islander partners. Manna Institute respectfully acknowledges the First Nations custodians of this continent and pays respect to elders past, present and emerging. They reflect and honour the rich cultural heritage, the beliefs and the enduring relationships to the lands and communities in which we all live and learn and work. I'm coming to you as a University of New England academic based in Sydney, coming to you from Darren and Green-Guy lands, where my home backs onto the songlines of the Great North Walk, a safe haven for women and children for thousands of years moving across our country. I'm hoping that this is a really wonderful opportunity for us to come together and collaborate on really important conversations, really centering the focus on regional mental health and providing an opportunity to look at both the professional, the industry, the academic and the lived experience reflections of those spaces. For some of you, this might be the first time that you're connecting with the Manna Institute. And so I think it's really important to reflect on what's the purpose of Manna Institute. And I'd also like to acknowledge that the director of the Manna Institute is here today, Professor Miff Maple. I've also placed in the chat box here the website that will take you directly to Manna, and encourage you as well at the end of our webinar to reflect on the resources that are available on that website and also consider some of the spaces in which you might connect on our social media platforms, as well as connecting with our newsletters, resources and upcoming events. I think what's really important to know as both a senior researcher with Manna and someone who's been a proud social worker and mental health researcher for a very long time is that Manna Institute equips communities to take ownership of the mental health and wellbeing of their members, to build capacity, to implement some targeted solutions, and to think about truly what the needs are of priority populations through that regional, rural and remote lens. It's a virtual institute, which sometimes sounds a little bit like it doesn't technically exist, but it very much does in terms of the passion and the focus of all of the capacity to bring together leading mental health researchers from 7 universities as part of the Regional Universities Network. That includes Charles Sturt, Central Queensland University, Federation University, Southern Cross, University of Southern Queensland, University of Sunshine Coast, and the lead institution, University of New England. It also collaborates with industry and community partners because it recognises that research can't just happen behind the walls of a university, that it's really about connecting with those community partners, which currently include Everymind, Lifeline Direct, and the ANU Centre for Mental Health Research, to really think about how we tailor solutions specifically to the regions. Today's conversation is really centering around the needs of the regional mental health workforce. Whether you're an undergraduate student, a postgraduate student, a person that works in the community, a person with a special interest in regional mental health, a person with lived or learnt experience of mental health, or somebody that just wants to open up the conversations to learn more about what we need to understand about the unique issues facing the regional mental health workforce. We've got a panel of speakers here today that are each going to reflect on different aspects of the regional mental health workforce individually. And then we'll have some opportunities at the end to come together and ask questions, to extend the conversation and to think about what we can learn and take away from what we hear today. And then also think about what we might like to come back to together and collaborate further. So I'm really happy to be facilitating this first webinar. Our industry speakers here today, and I'll get them to awkwardly wave as I say their names, is our first speakers are James and Michelle from Neami. They're going to be focusing on service delivery and the needs for the regional mental health workforce. James is a passionate advocate for communities in the prevention of suicide and mental health outcomes. And I've worked with him for a number of years and can very much attest to that. He comes from a background being the son of a Vietnam vet and developed an early appreciation for understanding the impact of war on individuals and their families and community wellbeing. He's the regional manager for South Queensland Neami National. I just made you international then, James, for a moment, and has experience in the not-for-profit and public sectors. He's also, and I will just add this in, a very proud social worker. We always need to see social workers out there in the community, extending the ways in which we can explore the individual and community-based approaches to mental health. Michelle is a mental health occupational therapist, so really lovely opportunity to see in action allied health professionals working together. And she's got significant experience in rural and remote mental health. She's worked in public and not-for-profit sectors, as well as in private practice. She works at Neami National as a clinical service manager for Connect to Wellbeing North Queensland, and is passionate about improving mental health service delivery and access in rural and remote areas. So after that very long intro that I've just done, what we're hoping to hear from James and Michelle today is about thinking about what the service delivery needs might be for regional mental health workforce. Thinking about those professional reflections on the realities of what helps you work in a regional setting, what some of the barriers might be, and what to do around, some of those boundaries that might come out in the wash that might be different from that metro-centric approach. So I'll hand over to the two of you.
Thanks for that lovely introduction, Sarah, and good afternoon, everyone. And I do like the ring of that Neami International. So Michelle and I might have to take that back to Neami board. But thanks so much for having me. And like Sarah outlined today, Michelle and I are just going to share about some of our experiences in service delivery within both regional, rural and even remote workforce settings. But specifically today, we're going to touch on some barriers and enablers around developing trust and engagement with consumers, also touching on staff development and supervision. And then lastly, we'll deep dive into professional boundaries as much as you can within a 7-minute window. So I'll get straight into it. So in reference to trust and engagement, a key barrier to developing trust often happens at the establishment of a program itself through the model conceptualization. And often models are developed and piloted within metropolitan settings and then look to be translated into more regional and remote settings without necessarily a lot of thought to the various intricacies of how services will be delivered. So to give you an example of that, there was a housing and homelessness service that we were looking to implement for people with a mental illness out within a regional hub in Queensland. And upon review of the service model, very quickly by looking at the deliverables, we identified that there was an expectation to do a set number of client hours over a set amount of time. When we unpacked that, there was an assumption made around staff travel that you'd be traveling about 10 to 15 minutes each way to see a consumer. So very quickly, we were able to identify, actually, if we were to implement this model, we would actually be at odds with service quality, but also not able to meet the expectations of the funder. In moving beyond service model conceptualization, we know that there's also barriers for people living in regional settings around place-based stigma associated with the services themselves. So it takes me back to when I was a community development worker working with the community of Devonport in Tasmania. And the community there identified that there was a local psychological services provider that was well regarded within the community. But the community noted that a real barrier for people accessing that service was physically walking in the building. People noted that the service was based in the main street. Walking into that service, there was a perception that their privacy was being impacted, that people would directly associate them even walking nearby the service provider that they were accessing, and they felt that their privacy was compromised. In addition to this, staff being known to consumers within a variety of settings can be a really compounding challenge within regional service environments. And so in reflecting upon this, it took me back to when I was first a case manager in the foster care industry. And so very early on, I came in contact with a foster carer, and she approached me, as she also knew me through my former high school setting. The foster carer was immediately concerned for her confidentiality and needing me to reaffirm my professionality, my ability to maintain her confidentiality, and that added an extra layer to our relationship from the get-go. But whilst these examples that I outline at the moment really identify some of the barriers, when you actually look at them and reframe them using my social work framework, but if you look to reframe them in the instance of the foster carer, whilst they had their initial concerns for privacy, her and I were very quickly able to build rapport because I was able to identify with her context, with the context of the challenges for the foster children that she was caring for within both the school-based setting that I'd formerly been a part of, but also like barriers to access with services, as well as recreational activities. And this enabled us to build that therapeutic alliance very quickly. And then whilst the psychological service provider in Devonport was difficult for community members to access in person, because they were known through people's relatives who'd accessed the services, there was a high regard for their service delivery. People who did access the service were able to also build that relationship very quickly and were more prone to seeking support as a result. It just needed a little bit more variety in terms of how people access the building, either a back entrance or telehealth. And then whilst the housing service model that I mentioned at the start was very much left wanting, what it did do was allow us as a service provider and others to advocate back to the funder for a revised service model, but also service innovations around group work, incorporation of technologies, and also about how do we actually deliver this service in a quality way. So next I'll touch briefly on some barriers in relation to professional development, and then I'll hand over to my colleague, Michelle. So while delivering services regionally in rural settings can provide a really rich and hands-on and diverse experience for workforce, when you're working rurally, you're often the sole person within the practice, within the service. And so if you're to go away to attend professional development through way of a conference, through way of, might be going into town for external supervision, the service is impacted by that workforce shortage in a different way that metropolitan counterparts would not be. Even things like taking leave and acquiring backfill, there isn't always an available clinician within a township to do so. Additionally, a real barrier can be that career progression, because you may secure a role at a clinician or a team leader level, but there's those limited opportunities to progress your career further within that organisation, within that community. Additionally, Michelle will probably share into some of these stories in a moment, but I know for Michelle, she lives out at Charters Towers. Now, the nearest airport for Michelle is Townsville, and various times Michelle's been flooded in and not able to even make it to an airport to get to a conference, or not to add even the fact that when you are going to a conference, perhaps in Sydney or Melbourne from such a locality, you've got extended layover and wait time, which again impacts on service delivery shortages, but also impacts on the staff members' well-being as they're away from family. So I'll now hand over to Michelle to talk about some enablers around professional development and lean into the professional boundaries.
Thanks, James. So, obviously there is quite a few barriers in terms of having access to the face-to-face professional development, but working rurally or remotely, there's also such an opportunity for rich learning on the ground. So the hands-on experience that you get is really broad. You know, initially I started out working in child and youth mental health, and I worked for a community mental health service which covered all ages. So I, you know, was working with child and youth mental health, older person's mental health, going on outreach, you know, and you can't put sort of a value on, you know, how much you learn actually on the ground. So the experience alone is huge for professional development. And then I guess, you know, with the increased availability now of telephone and online technology, you know, here we are in a webinar today, you know, I'm in Mackay today, I'm usually in Charters Towers. You know, there's increased access to phone supervision, you know, webinars, networks, allied health networks, clinical networks that you wouldn't usually be able to, you know, gain in person. So there's a lot of benefits to that. And also access to resources online. And in some instances, depending where you live in the rural location, there can be some financial incentives as well. So there, you know, there's a lot of positives around that, despite sometimes being quite isolated and not being able to physically travel. So, sorry, I'm talking a bit quick because I'm mindful of the time. I'm going to jump into talking about boundaries, confidentiality, and privacy. So this was a really big thing for me working. So Charters Towers, I'm not sure if people are aware of Charters Towers, but it's a community of around 10,000 people, including surrounding properties. At one point, I was the only private practitioner in the town. So, you know, you're very mindful of the fact that you're going to come into conflict, or there's going to be confidentiality issues. So some of the barriers, I guess, there's minimal anonymity. So, you know, people recognize you, you see people around town. I had some difficulties, I guess, because I have worked in Charters Towers mental health for a very long time in different services. So I had worked with people when I was in, say, the community mental health sector, and then going into private practice, people would seek me out. I had an instance where I worked with a lady previously in a domestic violence situation, and she sought me out in private practice. She'd separated from her partner while we were in therapy, and was having issues, sort of ongoing issues with him and his new partner. And it took, you know, I eventually realised that I was actually providing therapy to his new partner as well, and I was, you know, midway into sessions for both of them, and I couldn't disclose to either. I had to sort of maintain very strong boundaries. So that was a really tricky situation. There's been other instances where I have been, you know, seeing a teenager, and she disclosed she was having issues with another person. That was actually my son. So I had to call that out. I was like, oh, I'm, you know, so sorry, that's my son. Probably not the best person for you to be seeing, you know, and had to call that out and address that. So I think that's the biggest thing, you know, in a small town, there is a lot of, you run into that a lot. And so I guess in turn, the enablers and the ways to manage that is having very clear boundaries. So I would start every new session, I'd see every new person with, you know, we live in a small town, you know, we're likely to see each other. I won't say hello, I won't approach you ever in public, but if you come up to me and say hello, I'll say hello back. You know, you set those rules and those limits and those expectations as well. You reinforce, you know, that everything is confidential. And I guess really good supervision is very important, because when you do come into those ethical dilemmas or those things where you're faced with the conflict of interest, you know, you need to have really good supervision and ways to work through those. So I think, you know, and there are so many good things as well, because you build trust, and then, you know, reputation wise as well, which can be tricky because sometimes everyone wants to see you and you don't necessarily want to see your child's teacher and stuff like that. So that's very hard too. But I guess overall, I've always worked rurally. I moved to Charter Towers. I didn't plan to stay there, but 17 years later, I'm still there. And you know, now I'm remotely managing and traveling around. So it's overall, it's a really great experience.
Excellent. Thank you so much, Michelle and James. And what I'll do to make sure people don't lose the ideas in their mind is that I'll get you to use the chat box if you've got questions that you'd like to park that we'll come back to later. Because I think, you know, some of the themes that really jumped out for me from James and Michelle was around those practical challenges of working in rural when you know, organizations are talking about you can just travel down the road and see that person, whereas it might take all day to travel backwards and forwards to see one person, and what that actually means for a service and its goals. But I also think, you know, with my social work academic hat on, the challenges of meeting people, that there are dual relationships and that you can't have necessarily a boundary that says, I can't work with anybody that I know, because the reality is you might almost always know everybody. And so how to balance those two. So I'd really encourage people to pop questions in the chat and I'll come back to them later. Our next speaker is Professor John Hurley. He is a credentialed mental health nurse, and he's from Southern Cross University. He also works clinically at Headspace in Coffs Harbour, and he's got extensive experience as a mental health practitioner, particularly around psychiatric crisis and home treatment services in both Australia and the UK. So today we're going to be asking John to really consider from an academic and a clinician's perspective, focusing on mental health nursing and delivery of services to children and young people, and what are the needs of rural, regional and remote, you can never say that quickly, versus the city, and how can workforce prep themselves and be responsive. And also thinking, you know, given a lot of our audience are early career researchers or almost university graduates, what's important to better understand. So no big feat. If you could resolve all of that in 7 minutes, that would be really great. Yeah, I've started the clock. Thank you, John.
Thank you, Sarah, very much. And thank you very much, James and Michelle. I live in a small country town, and I have a clinic at Headspace with young people, and a lot of what you raised, Michelle, was certainly very familiar. Thank you. So welcome, everyone. John Hurley. I'm currently in Narna Glen on the Wagner country. Their greeting is G'day, so G'day. The issue of mental health workforce is one that we could probably devote the entire resources of the Manna Institute for the next 5 to 10 years without any issues whatsoever. It's an absolutely wicked problem. We know from multiple studies, scoping reviews, that there is a long-standing, current and unfortunately escalating workforce shortage in health workforce internationally, in mental health workforce internationally, and that problem only worsens the further you go away from a metropolitan centre. Simultaneously, mental health need increases the further you go from a metropolitan centre. So you have these two issues that happen simultaneously. You have increasing workforce challenges, at the same time, high levels of mental health need. And this has been a problem that has vexed greater minds, certainly than mine, about what to do about this wicked problem. A lot of people focus on the N equals, or the number of mental health workforce. And that raises all sorts of fascinating and potential research questions. The other issue is that it's not just about the number, it's about the capability of that workforce as well. So what you have, particularly in the Australian context, is the traditional disciplines, if you like, that are associated with mental health, and certainly I'll give a nod to the emergent lived experience workforce, the peer support workforce, and would even argue a case that we need to have a wider perspective of what constitutes a mental health workforce as we go forward, as a way to sort of drive and look for solutions in this topic. Is that the preparation at undergraduate level is incredibly generic. An occupational therapist will often not have a mental health specialist unit as part of their training. Social work, besides social work has options to take mental health subjects, but very often they're not specialised. I'm currently doing an Australia-wide national study of undergraduate nursing preparation for mental health, and it is, in many places, woefully inadequate. So we have a lack of specialist training at the same time we try to develop this future workforce. In the Australian context nationally, it's probably looking between 20 and 30,000 short of what's required. So that again, 20 to 30,000 short of what's required by 2030. When we take a regional lens, so I sit in the northern New South Wales PHN area, that area from the Queensland border out west down to Port Macquarie. Now we've got a youth suicide rate that's twice the state average. We've got some of the highest unemployment rates for youth nationally. We compete strongly with Longreach, I think, to be the highest in the country. We've got some of the highest rates of psychotropic medication prescription for youth in the entire country. And without offering a disservice to biomedical treatments, which are obviously vitally important, we know from all the evidence that there's a need for holistic treatments, treatments that address the psychosocial, spiritual needs of the individuals, as well as addressing trauma, as well as addressing the needs of those who do very much need medication-based treatments. So the problems, as you can see, is pretty multiple. You've got a shortage of workforce number, a shortage of workforce capability. You've got the fact that these worsen in areas such as ours, rural, remote region. You've got increasing mental health need, and the needs are only increasing in terms of speciality. If you think about climate-driven needs, think about 5 to 10 years ago, no one was really talking about issues of gender diversity and the mental health vulnerability of particular populations like that. The idea of the impact of trauma 5 to 10 years ago, mental health was known and emergent. And now we're having a deeper understanding of just how much that drives the needs of individuals. There are lots of problems there. So to put a sort of a research lens on it, where might early career and mid-career researchers be sort of starting to do some work? Some of the work that I'll do a small plug. Some of the work that we're doing at Southern Cross University is we're looking at mental health workforce for specialist populations, and that's quite an interesting topic to have a look at. We're having a particular look at mental health workforce capabilities for those children under 12 experiencing mental health and behavioural problems. There's reasonably good services for the 12 plus. You've got Headspace. I've been part of Headspace for 13, 14 years, and it's not without its critics. However, there are those sort of very specific, age-specific services that are national for that age group, quite appropriate to say. Something like 80% of mental health problems emerge in the 12 to 25-year age group. So it's obviously massively important. But we're increasingly aware that there's this group who are 12 and under who don't have Headspace access as yet, who have incredibly high need. And for those who live in rural, remote and regional areas, there is virtually few specialist services. In some places, there are none. So who's carrying that burden of care? Obviously, people like parents, teachers, sports coaches, communities. That's another incredibly rich area for research. Not just the actual mental health workforce, but also who's actually providing these services informally. What's the efficacy of those services? People like school teachers, increasingly, if you think about that age group, who does a child have the most contact with? Well, they have a contact with usually some sort of carer, That might be a grandparent, parent, family, and then the next most sort of frequent point of contact is with the school. So it's an increasing school-based burden. In lots of rural, regional, remote Australia, sporting teams are a big, or recreational pastimes are a big part of our community fabric. And those who lead and run and organise those are obviously another sort of rich source of research potential in terms of exploring not just the existing body of literature through things like scoping reviews and systematic reviews, but then to identify those gaps in the knowledge, and then to be looking forward at some sort of mitigating strategies that might be able to address the wicked problems that are raised in the first place. So it's about that sort of whole sequence of going, well, we've got this wicked problem, what's currently known, where can we target our resources? Now we know that place-based solutions seem to offer the strongest hope in terms of addressing some of the recruitment problems that deals with our volume. We then have to look at the capability, and those who work in mental health. And I'm nearly out of time, but I'll quickly do a plug. When we talk about mental health, please be aware mental health exists on a spectrum from mental wellness all the way through to mental illness. And the term mental health tends to sort of almost unconsciously focus our attention to the bulk of the population who experience mild to moderate problems, but that there's also this issue of those who are at the more severe end of step care, that sort of level 3s, 4s, 5s, or 6s.
Yeah. Thank you, John. I'm sorry, we're slow. I understand what we were all talking about before when we were saying, how do we have these really complex discussions in a short period of time? But I think that what also would be important to reflect on is just being able to note some of the projects, all of the programs, or some of the emerging research in these areas as well. I think when John described almost, like the Pac-Man of complex issues in regional, rural, remote around increasing mental health needs versus decreasing availability of mental health workforce, and what that space in between actually needs to look like, really talks to that point that Miff's left in the chat around the need to explore the value of generalist mental health work, and acknowledging that workforce can exist on a spectrum as well as people's lived experience. So that brings us to our third speaker this afternoon. I should say as a conflict of interest, is that our third speaker, Darren Wagner, is one of my current PhD students. Now, Darren has a very detailed background as a suicide prevention and postvention researcher, public speaker, lived experience educator, social justice advocate, a former police officer, and also someone with lived experience of complex post-traumatic stress disorder, and probably what sounds like the busiest person in the universe. Darren has worked as a peer support worker in both non-gov and government sector for the last 10 years. And he's also got experience in terms of responding to some catastrophic community traumas, particularly in the US. Now, Darren is always one to have a little bit of a joke and to explore really complex areas in a really engaging way. So I think some of the conversations that were prompted by John's reflections will really bring together the final part of the webinar in terms of talking about the peer workforce and suicide prevention, and what does it actually mean to push or grow the peer workforce, and how do we do this in a deliberately safe way? The exciting part as well from when the link will be going out with the recording to today's webinar to everyone that's here and people that had registered so that they could get the recording, is that we also have a really great publication around what it means to engage in discussions about what if you decide that you want to be a peer worker? How do you actually do it? What are the practical implications and what's the career trajectory? So we'll also be able to offer you that as a bit of a goodie bag from today. So I'll hand over to Darren, and he's going to speak for 7-ish minutes around that, and then we'll come back together for some questions. Thanks, Darren.
Thank you, Sarah. What a wonderful introduction. So, look, it's my distinct privilege to follow up from John. I'm just going to start with there because it was a perfect segue around that mental health segue, being a spectrum, and that mental health and mental well-being is on that continuum. So that's really what our peer workforce is supposed to. Kind of integrating into that mental health team, because I think the other thing that really spoke to me from John saying is what is that mental health workforce, that team, because peer supporters, peer workers, consumer workers have been around for probably within Australia 50 years, more recognized in the past 20 years. And as a profession, probably within the past 5 years. And I think coming back to kind of James and Michelle's points is around that. So I don't have to reiterate anything that any of the early speakers said, because our peer workforce is facing the same challenges, barriers in that space. So I just kind of like to start off with the definition again. Is first of all, what is a peer worker? Because that's often there's a lot of confusion around that. We hear about them. We've had experiences, good, bad. So what is a peer support worker? And I'm going to focus for the next 7-ish minutes on looking at a paid peer workers. So acknowledging that peer work is a really broad umbrella. So there's informal peer work, there's volunteer work, there's nurse to nurse, social worker to social worker. There is that peer space for all of us. I'm going to focus on the intentional use of that lived experience and living experience, because that's really what we, we're hired on a basis of, I think one of the things as our workforce, one of the most unique things about our workforce is that there's this criteria around a lived experience. Depending if you're going into drugs and alcohol, corrections, suicide prevention, suicide postvention, is that that criteria for that role, which is unique, is that you have to be able to be at a point that you've understood what your challenge is with that, whatever that criteria is. So that role that you're going into should, and sadly, it doesn't always. So sometimes we hire peers and they are seen as they can step into any role. So we can pop over and do this. An example I like to use is from a perinatal experience. I have a lived experience of childbirth. So I was a paramedic actually before I was a cop. So yes, I've had many lived experiences. So I have delivered 2 babies. Now, that may not be the same for someone who's capable of actually delivering a child. So my lived experience is quite different. So I may not be the best candidate for a perinatal peer worker role. So I think we need to start looking at, when we have peer work roles, do we understand what we're asking of that lived and living experience? Because like we said, mental health is a spectrum and it's a challenge. So sometimes someone is still currently living with, but managing quite well that experience, whether it was a trauma, drug usage, whatever that lived experience is that they've progressed far enough in their own recovery, been able to reflect, been able to upskill a little bit to actually pull that together, to be able to sit with somebody, provide hope, just that, recovery is possible, even through a suicide. So we have a lot of, I guess the biggest growth in our peer workforce has been from suicide prevention. So having to have an experience around suicidal ideation, sometimes it's loss and bereavement from that suicide, but being able to reflect on that, pull that together, offer hope that recovery is possible, in empowering people, just by being able to recognize strengths that maybe others don't see in them, giving them a voice, because often the people that have been traumatized or what has been done to them has left them feeling really disempowered, giving them kind of self-determination, giving them meaningful choices, and then really, being able to work around a lot of diversity and inclusion. So our peer workforce is quite broad. I think the challenges, the barriers, I'll start out with the negatives, is the fact that around pay rates. So like most disciplines, there's a massive shortage. Now, I always honor the fact that we've had a lot of peer workers come into their roles, and because we haven't had the proper frameworks around supervision, orientations, them really even understanding what their role is, that we've lost a lot of peer workers that were brave enough to step into those roles, weren't properly supported. The organization wasn't quite sure. Often, because I've worked in a lot of roles and I've gotten to speak to a lot of amazing peer workers, is the fact that there's well-meaning organizations, well-meaning teams, initiatives that pop up, but we don't have the correct frameworks in place how to support them. So our managers that manage and support that lived experience workforce just don't have the tools to meaningfully support. So when I talk about a workforce shortage, I always want to honor the fact that we've had a lot of people that were brave enough to step into those roles. And then because of the challenges, weren't able to stay in that as a career. So pay rates can be a challenge because often we're seen as an unskilled. So a lot of peer workforces are seen as an unskilled because you're just bringing that, you're seen as really just your story. And if that was the case, we should even be paying even higher, because I think people's stories are worth an awful lot more. So, from that point of view, but organizations struggle with how do we pay this person what they're worth. Training, my goodness, I could go on for days about training. And again, the challenges for our rural peers is the fact that, yes, our metro peers can attend a lot more trainings face-to-face quite easily, network. Our rural peer workforce just doesn't have that. They really are siloed and siloed within their teams and organizations, as well as geographically. The other thing around supervision, I think I get at least 2 emails a day asking, where can we get peer supervision? How do we create peer supervisors? What does that look like? So as a workforce, we currently don't have a peak body that really represents the workforce. So we don't really have a national or state voice that can help put some of this framework into place. There's a lot of discussion, and has been for the past few years. And I think it was mentioned, good supervision. So, meaningful supervision that is, meaningful for our lived experience workforce. But so there's a lot of challenges, very similar to all of the other things that were stated early on. So I want to focus on the positives at the end, because that's really why people come into these roles, like most of us do. If you're in mental health, you're coming into this role because of sometimes a lived experience. So I always honor the fact that we, all of us have a lived and living experience. However, what we want from our peer workforce is to be able to actually wear that badge, to say, I'm a peer worker, which means that often I'm a person who has had a mental illness. Quite proudly wear that as a badge of honor. And I think, as we were talking about, one of the challenges of being remote, rural, regional, is the fact that it's a small town. So the challenge is not just knowing somebody personally, but it's like, now I've offered up my story to a very small community. So it's going to get around everybody, every school teacher, every bus driver, every clerk. So that can be quite a challenge. And I think sometimes our peers aren't supported in a way that how to use that story meaningfully, and understand where there are boundaries around that challenge. So I think for me, and again, thank you, Sarah. I do have the distinct privilege from Manna. I've gotten a scholarship to actually focus the next 3 years on this issue around what's currently in place for our current peer workforce, but more broadly is what do we need for our expanding peer workforce, because it is expanding rapidly, and most new initiatives in suicide prevention, postvention, perinatal, drug and alcohol, We're being integrated into our multidisciplinary teams, skillfully and unskillfully. So I'm going to be looking at how do we do that better, so that we can grow this as a professional workforce, continue to upskill them, in that space. So again, just very, very passionate about this. 7 minutes will not cover it. So I will stop there.
Thank you, Darren. I appreciate the passion, and I also appreciate that we're being, one of my favorite terms at the moment is radical simplification. And I think that we're having those really important conversations about what pulls people into the mental health workforce, whether that be peer or non-peer roles, and what keeps people in that workforce. I think that the conversations around supervision are incredibly important. And I think that the whole conversation around generalist and community embedded approaches really speak to some of the kind of political and community-based conversations we're having at the moment. What I'm going to do is get Liz to stop the recording and thank those who are listening in, not